Глубоко уважаемые коллеги, доброе утро. Продолжаем работу нашего форума, посвященного 40-летию Центра Алмазова. Сегодня у нас пленарная секция, на которой вы можете прослушать доклады блестящих специалистов в области эндокринологии и кардиологии из разных стран. К сожалению, из-за проблем с ковидом никто из них не смог приехать лично, и даже никто не смог участвовать непосредственно, но все записали свои блестящие лекции. Первым человеком, который выступит, это будет Тим Каривар. Это ведущий, несмотря на свой молодой возраст, это ведущий в мире специалист в области заболеваний щитовидной железы и беременности. Он инициировал несколько крупных международных исследований, которые показали выдающиеся результаты, и он нам об этом расскажет. Второй выступающий профессор Тейлор – это человек, который один из ведущих специалистов в области сахарного диабета. И его задача, так он ее нам предложил, это новое понимание сахарного диабета. А действительно ли сахарный диабет обратим? Есть ли какие-нибудь данные в пользу этой гипотезы? Об этом мы сегодня услышим. Профессор Анкер, профессор Леон приглашены нашими кардиологами, тоже известные специалисты в своей области. Профессор Анкер будет говорить о таком известном классе сахароснижающих препаратах, как ингибиторах SGLT2, новые данные в отношении лечения сердечной недостаточности. И, наконец, профессор Леон нам попытается рассказать, есть ли разница между популяцией российской и популяцией жителей Норвегии в кардиоваскулярных факторах риска, а может быть вообще в кардиоваскулярных болезнях. Спасибо, с удовольствием. Я вам предлагаю послушать наших коллег. Сессия идет на английском языке без перевода. Спасибо. Начинаем.
Center in Rotterdam in the Netherlands, and it is my pleasure to talk to you about thyroid and pregnancy. Specifically, what I would like to discuss during this lecture is a brief update on the management and diagnosis of thyroid diseases during pregnancy. Before I continue, I would like to express my gratitude for the invitation to speak on this excellent webinar, and I look forward to discussing anything related to this lecture and answer any questions afterwards. So here's a brief outline of what I would like to discuss. I would first give you a brief introduction on thyroid physiology mainly, and then like to discuss subclinical hypothyroidism and Graves' hyperthyroidism during pregnancy. Because it is these two topics that I believe in recent years have seen the largest change in the way that we clinically manage them. Also at the bottom of the slide, you can see my conflicts of interest. So thyroid physiology undergoes major changes during pregnancy, and these are probably best explained according to this timeline on the bottom of the slide, starting with conception on the left and going all the way up to birth on the right. So first of all, there's various physiological changes that actually decrease thyroid hormone availability. We know that thyroid hormone passes the placenta and it goes to the fetus, meaning that there's a fetal consumption of hypothyroidism. Also, the placenta includes type 3 dehyalinase, which of course inactivates thyroid hormone. And on the other hand, there's also a rise in thyroxine binding globulin. Now, luckily, to compensate these mechanisms that would actually decrease thyroid hormone availability, there is quite a large and swift peak in human chorionic gonadotropin, or HCG concentrations. And HCG, of course, has a weak affinity for the TSH receptor, and therefore HCG can actually stimulate the thyroid during pregnancy to produce more thyroid hormone. And this is also reflected in the 3T4 concentrations that we see during pregnancy, because these slightly increase, causing, of course, via the negative feedback system, then the classical dip in TSH concentrations. Another important physiological consideration during pregnancy is that this increase in 3T4 concentrations by HCG, so this thyroidal stimulation by HCG is actually impaired in women with TPO antibodies. TPO antibodies, of course, reflect thyroid autoimmunity. And in TPO antibody positive women, there's actually not a higher free T4 concentration if there is a higher HCG concentration. But as you can see on the left part of my slide, in women that are TPO antibody negative, a higher HCG does actually, as expected, associate with a higher free T4 concentration. So it seems that thyroid autoimmunity impairs the thyroidal response during pregnancy to thyroid stimulation by HCG. So let's go to a brief case. Case number 1, very straightforward case, 32-year-old lady, first pregnancy, 8 weeks pregnant, and her GP tests her thyroid function because she complains of tiredness. On the right side, you can see the laboratory results. And what do you think is true about her thyroid function? Her TSH is 3.2, free T4 is 12.4. And do you think her thyroid function is normal? Do you think that her thyroid function actually fits with subclinical hypothyroidism because her TSH is above 2.5? Or would you say that her thyroid function actually reflects overt hypothyroidism because you feel that the free T4 is also low during pregnancy? I'm going to give you 5 to 10 seconds to think about your answer. Think about it by yourself. We can't really interact through this webinar. And I'm going to give you the right answer in a bit. So guidelines in the last 10 to 15 years have changed a lot, and for very good reasons. So if you look at the previous ATA guidelines, the Endocrine Society guidelines, or the European Thyroid Association guidelines, these have always recommended that you calculate your own reference ranges for your own hospital using your own assay. And if you couldn't do that, then the second option would be to use a fixed cutoff for TSH. No free T4 cutoffs could be provided at that time, and still we can't really do that. And those fixed cutoffs were TSH of less than 2.5 in the first trimester or less than 3 in the second or third trimester. Now, based on very relevant and important new data on reference ranges, the ATA guidelines in 2017 have changed. They still advocate that you calculate your own reference ranges in your own hospital using your own assay. However, if these are unavailable, then a second step has been introduced, which is actually to use calculated reference ranges from a hospital or a country that are similar to your hospital and population, and that have also used the same TSH assay. It's probably better to adopt those reference ranges than to go to a fixed upper limit of TSH straight away. You can search the literature. Also, our group has done meta-analysis and reviews on this topic. You can extract from those data what is best fitting for your hospital. If that still is not possible for you to generate hospital-specific reference ranges, then you can go to the third step, which is a fixed upper limit of TSH. But based on a lot of data, this is no longer 2.5 or 3, but the upper limit for TSH in the third option for these reference ranges for TSH has been 4.0 milliunits per liter. So a considerable difference. Here's the data that supports the use of a cutoff of 4 milliunits per liter, and also the preferred use of calculating reference ranges. In this meta-analysis by Stagnaro Green, published in Thyroid a while ago, they looked at the difference between calculating your own reference ranges, as in these graphs is shown by the left graph, left part of the graph, versus the ATA guidelines of 2011, which is the 2.5 to 3 milliliter per liter cutoff, versus the 4.0 milliliter per liter cutoff for TSH. So this sort of gold standard approach shown on the left for overt hypothyroidism in the left part of the graph, actually compared to the 2.5 to 3 milliunits per liter cutoff, is associated with a much lower prevalence of overt hypothyroidism. And if you would use 2.5 and 3.0 milliliters per liter, you would overdiagnose every woman that comes through your door. You would overdiagnose 1 in 120 women that come through your door with hypothyroidism. If you would use TSH above 4 as a cutoff to define overt hypothyroidism, this overdiagnosis would decrease to 1 in about 334. So quite a relevant decrease for this major diagnosis, which is overt hypothyroidism. For subclinical hypothyroidism, these differences are even larger, as you can see in my slide. So overdiagnosis, using the 2.5 to 3 milliunit per liter cutoff, is about 1 in 9 women. 1 in 9 women would be overdiagnosed if you use 2.5 and 3.0 milliunits per liter cutoffs for the diagnosis of subclinical hypothyroidism. However, if you increase this upper limit to 4 milliunits per liter, this is only 1 in 167, which really is a large difference for the prevalence of subclinical hypothyroidism. So let's go to a second case. This is a 26-year-old woman. It's her second pregnancy. She's now 10 weeks pregnant. Her rheumatologist screened her because she has rheumatoid arthritis, which is currently actually quiescent. And here on the right side, you can see her laboratory results. She has a TSH of 4.6 milliunits per liter and a free T4 of 11.4. So is there now an indication for treatment? Do you think there's not an indication for treatment, which is answer A? Would you say, well, I'm not really sure, this depends on other things? Would you treat this woman with 150 microgram of levothyroxine per day, or would you treat this woman with 50 micrograms of levothyroxine per day? I'm going to give you 5 seconds to read the question again and think about what your answer would be. Here, I think the correct answer would be option B. It really depends on the TPO antibody status of this woman, whether or not there's an indication for treatment. And the fact that she already has an autoimmune disease, of course, increases her risk for TPO antibody positivity. So here, with a TSH of 4.6, it would really make sense to also assess her TPO antibody status. Here's a brief overview of the current American Thyroid Association guidelines recommendations when it comes to treatment for TSH and TPO antibody status combinations. So in TPO antibody negative women, there really isn't a treatment indication if the TSH is below the upper limit that you use in your hospital, below the reference range that you use. If the TSH is above 10 milliunits per liter, there really is a clear treatment indication. But there's this gray zone, which is between above the upper limit of normal and 10 milliunits per liter, which I'm going to come back to. In TPO antibody positive women, there's no treatment indication when the TSH is below 2.5, but there is data which suggests that you should treat these women if the TSH is above the upper limit of normal. Here, the gray zone lies between 2.5 and the upper limit of normal that you use. So either your own reference ranges, adopted reference ranges, or a fixed upper limit for TSH of 4 milliunits per liter. So what do we really know about the treatment of subclinical hypothyroidism? The truth is we don't know a lot. Here you can see the main 2 randomized controlled trials that have been performed. First of all, there's the CATS trial, in which women with subclinical hypothyroidism or hypothyroxanemia were treated with quite a large dose of 150 micrograms of levothyroxine. Their main outcome was child IQ around the age of 5. And in this study, they didn't show any differences in the IQ of the child after 5 years. The second trial was performed by the NIH, published in 2017, where they treated women with subclinical hypothyroidism with a lower dosage of 100 micrograms, and also had a treatment arm for hypothyroxanemia, which they treated with an even lower dose of 50 micrograms per day. And although this trial actually showed that the IQ in the group of children of which the mothers were treated during pregnancy was 3 points higher, which is exactly in line with epidemiological studies that have been performed on this. The p-values, as you can see, do not indicate a statistically significant result. And this is because this trial was designed in 2005, when the expected difference would be 5 points. So this trial was actually powered to show a statistically significant result of 5 points. And now, unfortunately, they actually replicate the observational studies that we've seen in the last couple of years, showing a 3-point increase according to treatment, but they don't have the statistical power to show that this is actually statistically significant, unfortunately. Now, what's interesting is that both of these trials also looked at preterm birth and miscarriage and other outcomes, but they didn't see any differences in those outcomes. Unfortunately, these trials have not separated TPO antibody positive women from TPO antibody negative women. So it is not clear to what extent TPO antibody positive women would have a beneficial effect of treatment versus TPO antibody negative women. So there is some trial evidence from other studies that actually did stratify TPO antibody negative from TPO antibody positive women, and also looked at other cutoffs for TSH. So 2 randomized controlled trials were done in Iran. The first one, in which treatment was started in the 12th week of pregnancy, and in which subclinical hypothyroidism was defined according to the old cutoffs of 2.5 and 3 milliunits per liter, first looked at TPO antibody negative women. Here they found that overall there was actually a non-significant effect looking at preterm delivery between those women that were treated and those that were left untreated. Now, when they actually stratified their analysis, no longer looking at this 2.5 and 3 milliunits per liter cutoff, but looking at the 4.0 milliunits per liter cutoff, as now advised in the guidelines, of course, then they found that if subclinical hypothyroidism was defined based on a TSH below 4 milliunits per liter, there was actually, again, not a statistically significant difference for preterm delivery between the treatment groups. However, if the TSH was above 4 milliunits per liter, there was actually quite a large difference in the women treated with levothyroxine versus those left untreated for preterm delivery and a TSH above 4 milliunits per liter, indicating that if you diagnose subclinical hypothyroidism according to the right cutoff and treat a woman with levothyroxine, her risk of preterm delivery could be decreased because of the treatment. Of course, these numbers were quite low, and replication is still needed to confirm these results. A similar trial was performed by the same group, but now looking at TPO antibody positive women. Interestingly, in TPO antibody positive women, they found that in the whole group, there was again a lower risk of preterm delivery if TPO antibody positive women were treated with levothyroxine. About 24% in the TPO antibody positive group that was left untreated versus 7% in those that were treated. Again, here, they split up their analysis according to subclinical hypothyroidism defined by TSH below 4 milliunits per liter or above 4 milliunits per liter. Here again, in the group with the TSH below 4, there was no effect, and the TSH group above 4, there was quite a large effect of treatment. Again, supporting why we should diagnose subclinical hypothyroidism as a reference range defined in your own hospital, or if that's not possible, 4.0 milliunits per liter cutoff for the upper limit of TSH. There's also some observational data that indicates that there is a difference between TPO antibody positive women with a high TSH versus TPO antibody negative women with a high TSH. And those data seem to suggest that there's a synergistically higher risk of thyroid autoimmunity and a high TSH. So really the combination of the two. Here is the main paper that started this line of thought, published in Thyroid already 6 years ago, looking at the risk of miscarriage. So in this paper, they looked at the TSH between 2.5 and 10 and found that there was perhaps a slightly higher risk of miscarriage. When they looked at the TSH above 5.2, which was their hospital-specific cutoff according to their own assay, they found that this was 3.4 times increased. When they looked at women who only had thyroid autoimmunity based mainly on TPO antibodies, they found that this risk of miscarriage was 2.7-fold higher. But when they then started to look at the combination of thyroid autoimmunity with a TSH above 2.5, this risk of miscarriage increased even further, now 5-fold higher. And when they looked at thyroid autoimmunity with a TSH above their hospital-specific upper limit for TSH, it even went to as high as a 10-fold higher risk of miscarriage, really indicating that it is not only the high TSH or only the antibodies, but it's especially those women who are positive for the antibodies and have a high TSH that have the highest risk of adverse outcomes. We tried in the Consortium on Thyroid and Pregnancy to replicate these results and also look at preterm delivery. The Consortium on Thyroid and Pregnancy, which is something that also St. Petersburg and Dr. Popova has been a part of, is a large international collaboration in which we try to identify and collect the individual participant data from prospective cohort studies to perform large meta-analysis and look at the adverse effects of thyroid disease during pregnancy. And here you can see all the participating countries. By now, we have many more cohorts, up to 25 now, that are collaborating with us in this consortium. And you can go to our website, www.consortiumthyroidandpregnancy.org, and see some more information about this. And we're always looking for people to collaborate with us in these efforts to do these large studies on thyroid disease in pregnancy. So going back to what we found in our initial paper, looking at late and very preterm birth, there was a slightly higher risk of late preterm birth for women with subclinical hypothyroidism. There was a slightly higher risk of TPO antibody positive women for late preterm birth, but especially for very preterm birth, so below 32 weeks gestation. And when we looked at the combination again of TPO antibody positivity with a TSH above 2.5 or above 4 milliunits per liter, we again found that especially those women who are TPO antibody positive and have a TSH above 4 milliunits per liter have the higher risk of preterm birth. Now, unfortunately, we were not able to look at very preterm birth because we didn't have enough numbers to do valid analyses. But for the late preterm birth, we did see the exact same synergistically higher risk of adverse outcomes with the combination of antibody positivity and a TSH above 2.5 or 4 milliunits per liter. So with regards to the dosage of treatment for subclinical hypothyroidism or hypothyroxanemia, what is important is that there could actually also be a risk of overtreatment. So here you can see the association of maternal free T4 concentrations with child IQ or cortex volume in a study that we have recently published, showing that there seems to be this inverted Q-shaped association, implicating that it's not only the low free T4 concentrations that are associated with IQ and other types of outcomes related to neurodevelopment of the child, but also higher free T4 concentrations during early pregnancy may be associated with adverse neurodevelopmental outcomes. And based on these and other data, there's this hypothesis that there's an optimal treatment scenario shown on the left part of my slide, where you treat a woman with low thyroid function from the low spectrum of thyroid function to the middle of the reference range for free T4 and also TSH. And there's the overtreatment scenario, where you would actually go from the left side of the graph to the right side of the graph. and the net effect of the treatment is suboptimal or perhaps not even there. And further analysis of the CATS trial that I alluded to in my previous slide have actually shown that the treatment with 150 microgram in that trial in some women with signs of overtreatment actually led to children with a higher risk of ADHD and autism spectrum disorders. So verifying this concept and based on the observational data from our group. So please be aware of this risk of overtreatment. So those are the two main points I want to make about subclinical hypothyroidism. Use TPO antibody positivity to inform decision-making on the levothyroxine treatment. And also please be aware of the risk of overtreatment and just start with 50 micrograms and then titrate the dose up later during pregnancy if that's needed. On to the third case. This is a 32-year-old lady, first pregnancy. Actually, she wants to become pregnant of her first child, but she's now trying to conceive. So you diagnose this lady with Graves' hypothyroidism. And here on the right side are our laboratory results, overt hypothyroidism, and you also see that she has relatively high TSH receptor antibodies, so more than 4 times the upper limit of normal. Sorry, 3 times the upper limit of normal. So what are you going to do in this lady? Are you going to start her on methimazole or carbimazole and give her block and replace for at least a year? Would you rather start PTU and titrate the dosage? Would you refer her for radioactive iodine therapy or for thyroidectomy? Or would you educate the patient about all of these treatment options and then perform shared decision-making together with her to come to an agreement on which treatment to start? I'm going to give you a few seconds again to think about these answers and think about what you would do in a woman who wishes to become pregnant and then is found out to have Graves' disease. So I think that the correct answer here should be to educate her and to perform shared decision-making. So what you can tell her is the advantages and disadvantages of the various options. Now, if we think about methimazole block and replace therapy, first of all, she has to be willing to wait with pregnancy, especially because birth defects can occur if methimazole treatment is started and continued during early pregnancy. Also, if you stop block and replace therapy, there is about a 40% risk of relapse after a year. I mean, this of course depends on the risk factors at presentation, but you also need to discuss that with her. So preferably, if she wants methimazole, she should wait a year and hope that her Graves' disease doesn't return. And if it's stable, start with pregnancy. What's really specific about methimazole, if you compare it to PTU, is that there also seems to be a cumulative dosage effect. So in this large study published 2 years ago, the Koreans in a large data set looked at the risk of birth defects related to PTU and methimazole. And while they found that PTU was associated with a slightly higher risk of birth defects, they specifically also identified that methimazole treatment is associated with a higher risk of birth defects, but that there was also a dose effect for methimazole, but not for PTU. So as you can see from my slide here, which shows that a higher dosage of methimazole was actually associated with a higher risk of birth defects, while this was not the case for PTU. It shows that for every quartile of increase in this data set of methimazole, there was a 1.9-fold higher risk of birth defects, whereas this was not the case for PTU. Now, interestingly, the highest cumulative methimazole dosage was about 495 milligrams in the first trimester in total, which is equivalent to about 5 milligrams per day for 3 months. So already with quite low dosages, there seems to be a higher risk of birth defects according to methimazole. also for PTU, it would be sensible to try and achieve biochemical control with the lowest possible dosage. Because this study by the Danish showed that also for PTU, there is already a higher risk of birth defects. However, the absolute risk increase for birth defects for PTU is about 3%. So this risk goes from about 5 to 8%. For methimazole, it's slightly higher. It goes from 5 to 10% absolute risk. Also, if you compare PTU to methimazole with regards to the risk of fetal birth defects, the type of fetal birth defect is also different. So with PTU, we typically see milder fetal birth defects, either hydronephrosis or preauricular cyst or sinus, which sometimes need intervention by a surgeon, but not always. And this is compared to aplasia cutis or even an umbilical, as you can see on the right part of my slide, which are much more severe fetal birth defects. So again, in summary, PTU exposure is associated with slightly lower risk of fetal birth defects compared to methimazole usage, and PTU is also associated with less severe fetal birth defects than methimazole usage. So from that perspective, PTU really is the preferred antithyroid drug to start before or during pregnancy. So what about radioactive iodine? Well, if you discuss radioactive iodine with a young woman who wants to become pregnant and has Graves' disease, you need to tell her that this is really the strongest contraindication for pregnancy there is due to the radiation. So from a radiation point of view, it is advised to not become pregnant at least 6 months after radioactive iodine has been administered. But what you should also take into account is the fact that due to the radioactive iodine, TSH receptor antibodies can flare up. This beautiful study from the late Peter Lauerberg shows this in the left part of my slide, where there is an increase in TSH receptor antibodies after radioactive iodine treatment. Up to 1 or even 2 years, the TSH receptor antibodies are higher. So that means that the risk of Graves in the newborn, as is shown on the right part of my slide, could also be increased if a woman becomes pregnant after radioactive iodine, at least within 1 or 2 years after radioactive iodine, because of this flare in TSH receptor antibodies. And if you compare this to surgery or medication with antithyroid drugs, you can see that there's no flare with those treatment modalities, and that the TSH receptor antibodies actually quite rapidly decline. So you need to take that into account when you counsel this woman. Another more rigorous potential treatment for this woman would be thyroidectomy. So in case a woman wants to become pregnant as soon as possible, thyroidectomy is probably the safest way to go, because there's no increased risk of fetal birth defects and the TSH receptor antibodies don't flare up after this treatment. However, there is of course a lifelong indication for levothyroxine, and there's also the risk of surgery, which depends on the surgeon, depends on the center, but in general, about 15% of women can have long-lasting complications after surgery, such as hypoparathyroidism, for example. So in general, I would advise my patients to really think about the consequences of a thyroidectomy for the rest of their life. And I don't actively tell them not to go for thyroidectomy, but I do it a little bit inactively, because I think that the harms and the risks do not really outweigh the potential benefits as compared to PTU treatment, for example. So let's continue case number 3. I would have started her on PTU, maybe 75 milligrams, 3 times per day. So let's say you've done that 7 months ago, and she now calls you up to say that she is pregnant. 2 months ago, her laboratory results were as follows. As you can see on the right, she had a normal TSH, beautiful within the limits, and her free T4 also in the middle of the reference range. First of all, you would of course congratulate her that she's now pregnant, but what are you going to do next? Will you switch her PTU to methimazole? Would you consider increasing her PTU and starting levothyroxine? So go to block and replace therapy. Would you refer her for thyroidectomy in this stage, or would you try to stop the PTU and then regularly follow her up through early pregnancy? Again, please take a few seconds to think about what you would do in this case: methimazole, block and replace, thyroidectomy. I think the answer here should be to try and stop the PTU in early pregnancy and follow her up. And the reason for that is that if you think about the teratogenic period for PTU or methimazole for that matter, that really peaks between the 6 to 10 weeks of pregnancy, and it's probably safe outside the 5 to 16 week mark. So between 5 and 16 weeks is also considered a teratogenic period. What happens if you stop antithyroid drugs after you've treated her for 6 or 7 months is that, of course, the risk of the relapse of Graves' disease starts to increase. In some women, it will not come back at all. But if Graves' disease would come back, it's probably on average about 3 months after you stop antithyroid drugs. So let's say that you stop the antithyroid drugs when she's 5 weeks pregnant, then the risk of the relapse of Graves' disease starts to increase. And once you see that she starts to become hyperthyroid again, you can of course start her on a low dose of PTU again. But with a little bit of luck, she'll relapse after 3 months or even later. And that's when you have bypassed this teratogenic period between 5 to 16 weeks. And this way you can try and minimize the risk of antithyroid drug-induced fetal birth defects. Risk factors are very well described in the ATA guidelines. If there's a short treatment duration before they get pregnant, or if there's still a low TSH, or if you really need to use more than 10 milligram of methimazole or the equivalent of PTU, which would be about 200 milligrams of PTU per day, or if there's still signs of active Graves' disease, such as a high TRAb, a goiter, or orbitopathy, then probably you don't want to take the risk of stopping ATD. But if she does fulfill these criteria, you really can consider it. You also need to follow her up clinically and biochemically in the first or in every 2 weeks until 18 weeks of pregnancy to see and make sure that she doesn't flare in between. After 18 weeks of pregnancy, TSH receptor antibodies will start to decline because of immune tolerance related to pregnancy, so you can probably do it every 3 to 4 weeks from then on. Also, in Graves' disease, please don't forget to monitor the child, because the child can be hyperthyroid while the mother is considered euthyroid according to pregnancy reference ranges. What you can do is you can monitor the fetal heart rate and also monitor the fetal growth, because a hyperthyroid fetus has an increased heart rate and a decelerated fetal growth. You can also measure the fetal thyroid size using ultrasound. Here on my slide are some examples of measuring the fetal thyroid, and there's also actually reference ranges for this, as you can see in the middle part of my slide. Another interesting thing you can do is look at bone maturation, because the distal femoral ossification center doesn't appear before 32 weeks pregnancy in euthyroid pregnancies. But in hyperthyroid pregnancies, bone maturation is increased, and it can actually occur before 32 weeks of pregnancy. And an example of this is shown on the right part of my slide. If you see signs of hyperthyroidism, but the mother is not hyperthyroid, or there's any other mismatch between the mother and the fetus, and you want to know if the fetus is hyper or hypothyroid, sometimes it can also be necessary to do chordosynthesis or amniocentesis to measure the fetal thyroid function. But this is a decision that you need to make in a multidisciplinary team, of course. So here are some people I would really like to thank. Robin Peters is one of them. The other ones are mentioned on my slide. If you have any questions, if you want to collaborate on our consortium on thyroid and pregnancy, you can definitely send me an email, or you can look me up on Twitter, where I've also put some tutorials that give you some more details on what I've discussed in this lecture. And thank you very much for your attention.
Ladies and gentlemen, I'm very pleased to be talking to you today about a new understanding of type 2 diabetes. Type 2 diabetes now quite clearly a reversible condition, at least in its early stages. This picture shows Newcastle upon Tyne. Here is our River Tyne, together with our famous bridges. And it's a nice place to reflect, and it was reflecting upon the nature of type 2 diabetes, which I've done over the last 20 years, that led me to see a possible simplified way in which we could explain how it is caused. And that understanding led straight to a prediction, because by this idea, the twin cycle hypothesis, if people with type 2 diabetes were given a low-calorie diet, so they went into negative calorie balance, two things would happen. Firstly, in the liver, the amount of fat would be decreased, and that would improve insulin action, and that would result in the blood sugar being normalized overnight because of the important role of the liver in putting out glucose all the time under control of insulin. But separately, in the pancreas, a decrease in fat was postulated to be able to normalize the insulin response to eating, bring the beta cells back to normal function. Now, the only reason for expostulating a hypothesis is you can test it to destruction. And we tried to do that because we put people with type 2 diabetes on a low-calorie diet, asking two questions. Can early type 2 diabetes be reversed to normal? And secondly, what are the underlying mechanisms? This is a graph of fasting blood glucose over the 8-week duration of the study. On day 1, we stopped the metformin tablets that these people were on and commenced an 800-calorie diet. And this is what happened. Wow. We were astonished by these results. Fasting plasma glucose became normal within 7 days. It fell from an average of 9.2 to 5.9 millimole per litre. It remained steady over the rest of the 8-week period and close to that of a non-diabetic control group here. And we published these startling data in 2011. But the study was designed mainly to look at the mechanisms. So we were able to say at the end of it that the rapid fall in plasma glucose was due to a rapid fall in liver fat, rapid normalization of liver insulin sensitivity, not just improvement, normalization. But in the pancreas, a very gradual fall in pancreas fat and a very gradual return of first phase and maximal insulin responses. The beta cells seem to be able to wake up when the burden of fat was removed. Let me just show you one slide from that particular study, and that illustrates a change in liver fat. Here we see an ordinary MRI scan across the abdomen, but not quite ordinary, because this was done in such a way we could color code every pixel on the scan. And the key is shown over here. Red pixels are virtually 100% fat. So of course, fat under the skin is red. And at the other end of the scale, if there's no fat, it looks, beyond blue, it looks black. Inside the aorta, of course, it's black. But just look at this large organ here, the liver. It is an unpleasant greenish blue. And indeed, this person had 36% liver fat, even though they were regarded as having very ordinary type 2 diabetes. And we learnt that almost everybody with type 2 diabetes has elevated liver fat beyond what they can cope with. But over 8 weeks of low-calorie diet, bang, it all goes. It returns not just to normal, but to low normal, 2%. So a dramatic change we can bring about by grasping that type 2 diabetes is a condition of more energy stores than an individual can cope with. But of course, one good study leads to another. And so in 2011, when we published these data, we were asked 2 major questions. Firstly, is this reversal durable? Will it last long term? Because surely it's just a starvation phenomenon, is it not? The second question was, how about longer duration type 2 diabetes? Because we had studied solely diabetes of up to 4 years duration in this first dramatic study. So we set about finding the answers to these questions. And in the larger counterbalance study, we found, again, liver fat dropped dramatically after the low-calorie diet period of 8 weeks. We left it 2 weeks to equilibrate and get onto a normal calorie balance for the individual. But it still remained normal. And more to the point, 6 months later, with weight being kept steady, it remained absolutely rock solid. HbA1c fell from 7.1 at baseline to well within normal, 5.8%, 5.9% at 6 months. So there is no doubt that once diabetes is abolished, it will stay away provided weight remains stable. Duration. Did the duration of diabetes matter? Because in the counterbalance study, we accepted people of any duration. And in fact, it does matter. Our longest duration patient, of about 23 years, certainly did not reverse. This is the fasting plasma glucose achieved after the 8 weeks of calorie restriction. And you can see that the greater the duration, the less likely is the chance of reversing. Short duration, most people reversed. Not everybody, but most people reversed. Now, it's important to emphasize that yes, the chance of reversal diminishes, but it's never too late, possibly. I have had 2 people of duration 24 years who have stopped all their agents and gone back to normal. So it is a percentage chance we're talking about here, not the biological fixed possibility. Well, that's enough science for the moment. Let's look at other parts of Newcastle. You may wonder why Newcastle is called Newcastle. Well, indeed, here is the reason. This is our castle that was built in the year 1186. Now it's very old, but somehow the word stuck and we're still Newcastle. So we have fine old buildings and we have a fine cathedral. But this is out there in the community. And of course, that's where type 2 diabetes has to be managed. For that reason, we moved on to run the diabetes remission clinical trial, DIRECT. And we had one major question: can long-term remission of type 2 diabetes be achieved in primary care? Primary care, where the nurses would see a patient, but those nurses had 8 hours of structured tuition in how to do it. We recruited almost 300 people with type 2 diabetes duration of less than 6 years. When we designed this, we were still partway through the counterbalance study, and we thought we had a good idea of the most profitable duration to go for. And indeed, so it proved. The general practices were the unit of randomization, and they were randomized into intervention, where the nurses, sometimes dietitians, if there were dietitians, were trained to be able to bring about this 15 kilograms weight loss with people living their ordinary lives out in the community, compared with control, where the diabetes was managed according to normal guidelines, drugs, whatever was necessary to keep the blood sugar down. 149 people in each, and followed up for a total of 24 months. This is the diabetes remission clinical trial, so let's cut straight to the important answer. Did we get remission? Well, yes, we did. Here is the percentage of the intervention group in remission, and you'll see 46% at 12 months. Small percentage in the control group. Of course, anyone taking part in this study would realize the nature of the study. Some people took it into their own hands to really cut back on their food and achieve considerable weight loss. But overall, the weight change was small in the control group and remission was small. But let me explain this dotted red line. My colleague Mike Lean and I had calculated in advance that we would need to have about 22.5% of people in remission for this to be a worthwhile clinical intervention, worthwhile in personal health terms, worthwhile in health economic terms. But in fact, we far exceeded that 22% notional target. We got 46%. Now, were we still above this notional level by 2 years? Because of course, people will run into problems in everyday life, weight tends to creep up. Well, yes, we had 36% still in remission at 2 years. A very worthwhile and highly cost-effective intervention. We looked at all the aspects of the mechanisms underpinning the control of diabetes that we had previously identified, but I want to show you the most dramatic of these, and that is the maximal insulin response. If you like, a measure of the total number of beta cells. You'll see it increased from about half, 0.5, at the time of recruitment, all the way up to almost the same as the control group shown in the dotted line. So a doubling of beta cell mass. This clearly underscores the fact that remission is very different from merely diet-controlled type 2 diabetes. The beta cell can be recovered and brought back to normal in early type 2 diabetes. This is related entirely to the change in pancreas fat. You see in responders shown here, there was over a 1.5, about 1.8% decrease in absolute terms in the amount of fat in the pancreas. Those people who failed to keep their weight down and went back to baseline actually lost all this advantage, put on the fat again inside the pancreas, beta cell function went down, the diabetes came back. So yes, it is the fat inside the pancreas which is causing the main mischief. So how does this relate to your patients and my patients that we see in the clinic? Well, here we've gone back to the Newcastle quayside. Here is our famous Millennium Bridge. It tilts around this axis to allow boats to travel up and down the River Tyne here. But the point of this slide are these people who will get type 2 diabetes. And that underpins the question I'm sure you are asked in clinic, as I am. Why have I developed type 2 diabetes? Often coupled with the statement, all my friends are fatter than me, but they don't have diabetes. Well, I think we can now explain this by careful consideration of solid information. Let's just start with an imaginary distribution graph of BMI. So this is BMI, but instead of the usual smooth curve of distribution, we've put dots, one for each individual. Some people are quite light, other people are heavier. And in fact, this distribution I've lifted from the United Kingdom Prospective Diabetes Study. This was indeed the original distribution of BMI at recruitment. So let's just park that up here. Here we have the individuals. But just imagine if these individuals had been one generation earlier and they had been 15 kilograms lighter, because that's about the difference that we see. Well, those individuals would not have diabetes. Here we see the same individual, but an earlier person, 15 kilograms lighter. Alternately, you could say, well, what would happen to this person if they lost 15 kilograms? What would happen to this person if they lost 15 kilograms? And extrapolating that, let's just come back to the clinical situation, because in your clinic, you will have one person in front of you in the consultation. So let me introduce you to Fred and Mary and Bill. Fred lost 15 kilograms and became blue, lost his diabetes. So did Mary, and so did Bill. But let's just look again, because Fred is still obese. His BMI is over 30. Mary is still overweight. Her BMI is between 25 and 30. And Bill was told by his nurse that on no account should he lose weight, because that would be unhealthy at a normal BMI. Clearly, this is nonsense. Individuals are individuals and have their own set points. And so we can see that if a person has developed type 2 diabetes, they've become too heavy for their body. And we can give this a new term. And I propose that this should be called the personal fat threshold. If a person exceeds that, then they will run into diabetes if susceptible, and only if susceptible. Let me bring it full circle to consider the practicalities. How can people learn about this? Well, we've put all the how to do it information on our website, which is shown here. And also this year, I've published a book describing how to understand type 2 diabetes, what's really going on, and how to reverse it. So in this short talk, we can end up back at the Newcastle quayside, looking at the Millennium Bridge illuminated at night, and see just two simple conclusions. Firstly, early type 2 diabetes is reversible by 15 kilograms weight loss. That is easy to achieve with this particular method. Secondly, type 2 diabetes is caused by excess fat inside the liver and, importantly, inside the pancreas. Thank you for your attention.
Dear colleagues, it's a great pleasure to be with you in this virtual way. We are living in difficult times, and sometimes you have to revert to these approaches to really continue with the exchange of information and medical learning. Now, it's my job here to present you some update on SGLT2 inhibitors and how they're used in heart failure patients. And I can tell you this year's ESC meeting was really a very good source of information to this end. You know that, of course, over the last 20 years, there was a lot of progress in how treatments for diabetes were developed. And we have GLP-1 agonists, we have DPP-4 inhibitors, and we have SGLT2 inhibitors that basically trigger the excretion of sugar by inhibiting its renal reabsorption. This way, you lose sugar, you lose energy, you lose a little bit of weight, you regulate glucose, and of course, reduce blood pressure, and that has cardiovascular benefits. And now, over the last 10 years, clinical research programs have started, and the cardiovascular outcome trials in diabetes were rather successful, particularly the EMPA-REG outcome study. This has led to the idea, with the reduction in heart failure hospitalization seen in all these trials, that this could be useful for heart failure patients. And second, it has led to the idea maybe we can even use this outside of diabetic patients in the non-diabetic patients. Such trials have taken place and reported for the first time last year, and that's the DAPA-HF trial. And you see here the primary composite outcome of dapagliflozin versus placebo in heart failure patients with reduced ejection fraction. And the exciting thing was not only that there was a 26% reduction, but in this trial of 4,744 patients, the effects were very much the same in diabetic and non-diabetic patients. This was really a breakthrough. At this year's ESC meeting, and this is now the main part of my presentation, we presented the Emperor Reduced trial. Milton Packer gave the presentation, and with him and Javed Butler, Gerasimos Filipatos, and Fayez Zanat, as well as Stuart Pocock, I have the pleasure to really be involved very much in this study. And I shall share some information for you on this. And then I will show you the meta-analysis and put it in context with other recent data. Now, when you talk about empagliflozin, you're talking about a once daily medicine. You have one dose of 10 milligrams, and basically you don't need any titration. You just start the therapy. And we developed this trial program to have a particular assessment of the time to a first event of heart failure hospitalization or cardiovascular death. And then we investigated additional endpoints. When the trial was basically designed, we wanted to enrich it for hospitalizations for heart failure. And we basically made sure that the patients had higher NT-BNP values, the higher their ejection fraction is. And the patients basically, when they were included, also they had to fulfill certain blood pressure criteria, and the patients had to, of course, have a minimum amount of kidney function. The latter part is very important because the GFR usually is used as an exclusion criteria when it is below 30, but in this trial it was below 20. Now, when you see the baseline characteristics, you will see that, of course, 67 years of age and 24% being female is a very normal thing in our heart failure trials. But here we have an average ejection fraction of 27 and an NT-proBNP value of 1900 at baseline, making this a sicker population than the DAPA-HF population. When you then talk about the GFR, it's 4 milliliter lower than in DAPA, and you can see also we had ARNI at the baseline in 20% of patients. To cut a long story short, the patients benefited from this a lot. The combined endpoint of cardiovascular death or heart failure hospitalization was reduced by 25%. The number needed to treat for this is 19 over the 16 months follow-up in the study, and the absolute risk reduction is 5.2%. And if you look here into the components of the primary endpoint, you can see that there is a reduction in first hospitalization for heart failure by 31% and of cardiovascular death by 8%. You see that the confidence interval for cardiovascular death is as low as 0.75 and as high as 1.12, not significant in this study in itself. Now, the pre-specified subgroups, and this is very important for judging whom to treat and not to treat. And on this slide, I would like to highlight the one top subgroup, the baseline diabetes status. Half the patients had diabetes, half didn't. And in both subgroups, the treatment worked in a significant way. So this 100% now confirms and validates that in non-diabetic patients with heart failure and reduced ejection fraction, we can also use SGLT2 inhibitors to derive benefits. Now, if you continue then looking at other pre-specified subgroups and look here particularly at the bottom two ones, you can see that even when patients received best treatment for heart failure, and best treatment means they received an MRA and or they received an ARNI, even when they received these therapies, the results were significant, very similar between patients with and without these therapies. So even on best therapy, this treatment works. Now, when you are testing in such trials the primary endpoints and you win on the primary endpoint, you can continue to look at more hierarchical endpoints. And the first and recurrent heart failure hospitalization was second in the hierarchy, and very strong reduction, 30% in this trial, starting very early on, highly significant already at 180 days. There's really a lot of saving of hospitalizations with this very simple therapy in heart failure patients. Now, an aspect that is getting increasing attention is the protection of kidney function. And with an SGLT2 inhibitor here, empagliflozin, you can protect the kidneys. You can reduce the slope of decline in GFR over time in a highly significant way, as you can see also with other studies. But with an SGLT2 inhibitor, one thing is important to mention. You have a reduction in GFR in the first 4 weeks, but thereafter you stay stable for many years. Now, when you talk about the kidney, you talk also about kidney endpoints. And basically, this was also possible to document here for the first time that you can reduce them. What means kidney endpoint? Well, basically, it means the presence of end-stage kidney disease with chronic dialysis or the need for a transplant, or sustained profound decreases in eGFR. And such events were halved by empagliflozin against placebo. Now, at the ESC, we also saw a CKD trial, and this is dapagliflozin, and looking into these renal endpoints in CKD patients per se, looking at this and combining the renal endpoints with cardiovascular death, you can see here a 39% reduction. And of course, you know, heart failure patients are also CKD patients. CKD patients are also heart failure patients, confirming this is possible. And when you look in these 4,300 patients into the components of it, you can see that there is quite a strong benefit on all sorts of kidney endpoints. Cardiovascular mortality in this particular study, not significant, 19% reduction. Now, events is a good thing, and Emperor Reduced was very successful on them, but you also want to improve quality of life. And I can reassure you with empagliflozin, like with dapagliflozin, you can also improve quality of life in a significant way over time. Looking at serious adverse events, well, of course, in such patients, the biggest group of serious adverse events are really the cardiac disorders and, of course, also the renal problems. But if you look, for instance, into the 3 important categories of symptomatic hypotension, hypoglycemia, and ketoacidosis, there was no difference at all. So empagliflozin doesn't have many safety problems, if any. Now, interesting is genital tract infections. We previously believed that with SGLT2 inhibitors, you have 3 to 5% of patients more with genital infections. Look at the data here, 1.7% versus 0.6%. It's only a 1% increase. So when you teach patients about hygiene and how to do this properly, then basically you can prevent these problems. So summarizing this part, there is a strong effect on cardiovascular death and heart failure hospitalizations, and also the secondary endpoints with recurrent hospitalizations for heart failure or reductions in GFR. Now, the big question is, what about the comparison with DAPA-HF? And I told you already that the Emperor population was basically more prone to hospitalizations by being somewhat sicker. But the results overall, as published in the Lancet last weekend, show that there is no difference at all in cardiovascular death or in the primary outcome of first hospitalization for heart failure or in cardiovascular death. There is no difference between the trials. The results are very similar, no significant interaction between the trials at all. And if you look for diabetic and non-diabetic patients, these trials reinforce each other, that in non-diabetic patients, you get as much benefit as you get in diabetic patients. Some questions remained over the old age. What about patients 75 years and older? They equally get the benefit. There is no significant interaction at all. And if you look into the different age groups, the very young patients, there is a wide confidence interval. So the power there is very little. But in anybody above 55, you can see significant results, even in the subgroups of different age groups. So there is a lot of benefit. So let me come to a conclusion. In heart failure, we have big problems with hospitalization and premature death and with poor quality of life. We want the patients to get a better care, so we need to give them the medicines. And here, if you look at the blue bars, is a big analysis basically about patients who didn't have a contraindication and still didn't get guideline recommended therapies. 26% to 86%, depending on which drug we are talking about, of patients do not receive certain medicines. Now, with SGLT2 inhibitors, you don't have electrolyte imbalances at all, as you have with other drugs. And with SGLT2 inhibitors, you have a once daily dosing, a single dose only, and no titration. So it couldn't be easier to give SGLT2 inhibitors. And I suggest this update from the ESC tells us that DAPA-HF and EMPEROR-reduced show very similar results, that SGLT2 inhibitors are now part of the basic fundamental therapy for heart failure patients. And let me conclude by saying there are 5 pillars of heart failure therapy today in 2020. Rasiani is one, beta blockers, MRA, and SGLT2 inhibitors as the new addition. And of course, you may want to use loop diuretics because loop diuretics manage symptoms. But if you want to reduce morbidity, mortality, besides MRA, beta blocker, and RASI therapy, use also SGLT2 inhibitors. Thank you so much for your attention.
So hello, I'm David Leon. I'm Professor of Epidemiology at the London School of Hygiene and Tropical Medicine. I'd like to thank the organisers for inviting me to speak at the Congress, and I'm very sorry that we can't all meet up due to COVID. So I'm going to talk about large differences in a biomarker of accelerating cardiac aging between Russia and Norway. The authors of this work, the people who contributed scientifically to the work, it's a large number of people. I'm just wanting to acknowledge on this slide that they're from very many different institutions in Russia, in Norway, in UK, and so on. We have no conflicts of interest to declare. So the starting point of my presentation is a slide which I'm sure everyone will be familiar with, which is showing that cardiovascular disease mortality in both females and males in Russia is very different from in typical Western countries such as England and Wales and Norway, which are shown on the screen. Since 2005, cardiovascular mortality has been declining steeply in Russia, which is a great thing, but there is still a substantial gap between Russia and the two example countries here, England and Wales and Norway, which at younger ages, under the age of 70 years, is 8 times. So in other words, under the age of 70, cardiovascular mortality in Russia is 8 times higher than in Norway and England and Wales. So although things are going in the right direction, there's still a very large gap. So the question is, what underlies that gap? We established about 6 years ago now a collaboration through a project called the International Project in Cardiovascular Disease in Russia, of which one important component is the heart-to-heart collaboration. This is principally a collaboration between our studies in Russia with those of colleagues in Norway. And the objectives are to improve our understanding of the reasons for the large differences in cardiovascular disease rates between Russia and Norway, and to use this knowledge to inform policy aimed at reducing these differences. So it's got 2 components, really. So this is a graphic showing aspects, the key aspects of the heart-to-heart collaboration. We have conducted cross-sectional studies in Arkhangelsk and in Novosibirsk between 2015 and 18. This is based on something like 4,500 men and women aged 35 to 69 years, where we collected a considerable amount of information from them through interview and through medical examination. Here in Tromsø in Norway, at roughly the same time, between 2015 and 16, a larger number of men and women aged 40 plus years were also examined. And some of the examination protocols were very similar. This actually involved many institutions, as I've already said, in Russia, Norway, and elsewhere. So if you're interested, you can find out more about the Know Your Heart study, which is the Russian component of the heart-to-heart collaboration. And this was published in Wellcome Open Research, and also the web address at the bottom is our web page, which gives a lot more information about the work we've been doing. So the scientific question the overall scientific question that has motivated us is, how far do established cardiovascular risk factors explain differences in cardiovascular mortality rates between Russia and Norway? Now, of course, quite a lot is already known about factors which predict cardiovascular event rates, mortality, myocardial infarction, stroke, and so on. And this is reflected, for example, in a recent publication from Lancet Global Health from last year, in which the WHO score algorithm, which is used to predict individual risk in a clinical setting, was revised to calibrate it properly with the overall disease rates in any particular population. So this was an important step forward for the WHO's score predictive algorithm. And using very established and simple cardiovascular risk factors, which are sex, age, smoking, systolic blood pressure, cholesterol, and history of diabetes, the score system then gives you a prediction of the 10-year risk of a cardiovascular event, as I know you're all aware of. But we used the core data from this to do with the relationship of each of these factors to cardiovascular risk to try and address the following question. We applied the Norwegian risk factor profile for these established cardiovascular risk factors to Russia in order to try and see if Russia had the same risk factor profile for these factors as seen in Norway. How much impact would that have on the gap in cardiovascular mortality between Russia and Norway? So here, this slide looks at ischemic heart disease mortality, one component of cardiovascular mortality as a whole. The left-hand panel for men, the right-hand panel for women. The vertical axis is mortality rates from ischemic heart disease, and the horizontal axis is age. So one can actually see that as age goes up, of course, the risk of ischemic heart disease mortality goes up, but the red line is for Norway and the blue line is for Russia. And you can see the substantial gap, which is there in absolute terms. But if we think of the counterfactual and apply the cardiovascular risk profile seen in today in Norway to Russia, what happens to the mortality in Russia? Well, here it is. It's this dashed line. It's reduced. It gets closer to that of Norway, but it's not entirely eliminated. So for men, it reduces the difference by 33% between Russia and Norway, and for women by a smaller amount, by 22%. So the conclusion here is, for a number of reasons, just applying the cross-sectional data on risk factor profiles from Norway to Russia only explains a maximum of a third for men and a fifth for women. So we have explored a new direction to understanding these differences, and it was inspired by some work which we found from the Mayo Clinic in Minnesota in the USA. This is one of the early papers, which was published in point of fact just last year. where they had used artificial intelligence analysis of 12 ECGs to predict low ejection fraction. And this is what this paper, which is published, as I say, in Nature Medicine last year, is about. But at the same time, they also explored something rather interesting, which is the extent to which using data simply from a 12-lead ECG, you can predict someone's age. Now, of course, from a clinical perspective, this isn't particularly interesting. If a clinician is facing a patient, they don't need to actually give them a 12-lead ECG in order to determine their age, because you can just ask them. But there's an intrinsic scientific issue here, which is, to what extent is there information in the ECG about people's age? So this is data now from an analysis at the Mayo Clinic of nearly 500,000 individuals, patients from the Mayo Clinic, where they actually contrasted chronological age on the horizontal axis with the predicted age, the ECG predicted age, using convolutional neural networks. And you see that the each point, each blue dot in this cloud represents a single one of the 500,000 people. And you see that generally there's a relationship between chronological age and ECG predicted age. But for anyone who actually of a particular chronological age, there's a variety of different ages that are predicted by the ECG. So someone who's up here is going to have a higher predicted age than they really are, and someone below the red line is going to have a lower predicted age. So could we see this being above or below the line of identity? The line of identity being the point at which someone would be if their ECG age was exactly the same as their real age. Could we actually see, could we actually regard this difference, this deviation above or below the line, as a marker of cardiac aging, irrespective of someone's chronological age? So could differences between ECG predicted age and chronological age be a marker of the rate of cardiac aging? That was our thought. So we actually extended our collaboration, the heart-to-heart collaboration, to include the Mayo Clinic in Minnesota, because they had developed an algorithm based on these 500,000 American participants. And we asked the question, is the rate of cardiac aging greater in Russia than in Norway? So we were able to use the 12-lead ECGs, the digitized 12-lead ECGs, which were collected in the Tromsø study and in the Know Your Heart study. And this is the study design. So here we actually have Russian participants. We asked them their real age. We took the 12-lead ECG and then sent that to the Mayo Clinic, and they then returned to us the predicted ECG age, which we were then able to then relate to their chronological age. The same for the Norwegian participants. And so we can then construct a graph, as I've shown you before, chronological age on the horizontal axis, ECG age on the vertical axis, and see where people lie on that. And in particular, where are Russian participants and where are the Norwegian participants? And we've also introduced the concept of what we call delta age, which is the deviation of any one individual from the line of identity, i.e. how far above or below the line which actually relates to people who have an identical chronological age and their ECG age. So a delta age, which is negative, would suggest that relative to the American situation from the Mayo Clinic, people are younger, have a younger cardiac age, and a positive number is above. It means that they've got an older age. They've got possibly accelerated cardiac aging. So delta age is formally defined here as the difference between ECG age and chronological age. So in the Russian study, the Know Your Heart study, based on just 4,300 people, the mean delta age was plus 5.3 years here. And for the Norwegians, it was minus 2.3. In other words, relative to the American Mayo Clinic, on average, the Russians in Know Your Heart were 5 years older, their hearts older than their chronological age, and the Norwegians were 2.3 years younger, meaning overall there was a difference of 7.6 years. This is a scatter plot where each point represents an individual from one of the two studies. In the left-hand panel, it's the Know Your Heart participants who are highlighted in blue. In gray, we see behind them the Norwegian participants from the Tromsø 7 study. The yellow line here, diagonal line, is the line of identity, where someone would lie if their chronological age was the same as their ECG age. And the same data is just shown here, except here we've highlighted and brought to the front the points related to the Tromsø 7 study. And you can see here graphically the way in which the Know Your Heart participants tend to lie above the line, and to a greater degree, the Norwegian Tromsø 7 participants, particularly older ages, tend to lie below the line. So if we want to look at that distribution, the two distributions of delta age within each study, and reminding you delta age is simply the difference between ECG age and chronological age, we see here on the red distribution here for Tromsø 7. It's a relatively nice normal distribution, but it's considerably to the left of the blue distribution, which is the Know Your Heart distribution of delta age, with a gap, as we've already seen, of 7.6 years. Now, I'd like to contrast this with what we see for systolic blood pressure. It's known and widely known, in point of fact, that systolic blood pressure is actually higher in Russia than it is in many other countries. It's something like 4 millimeters of mercury in this subset. But compared to the distribution of delta age, there's considerably greater overlap for systolic blood pressure. So for one of the classic risk factors, we see much greater overlap than we see for this new biomarker delta age, suggesting that delta age has even more information in it. So one of the questions is, do risk factors explain differences in delta age between studies? And by risk factors, I mean many of the classic risk factors. So we've looked at that. So here is a very simple table. Just look at these two numbers here, 7.56. So this is the unadjusted difference between Know Your Heart and Tromsø 7 in terms of delta age, which is, as we've seen before, is 7.6, 7.56 years. And if we adjusted for all these factors, whether it's systolic blood pressure, BMI, pulse rate, LDL, HDL, diabetes, left ventricular hypertrophy, whole range of things, it's only reduced to 5.86. Now, this is not a surprise in a way, because we have already established that using cross-sectional measures from these two studies of similar sorts of risk factors, that we can't explain differences in mortality between the two countries, or only a little of it. So it's not surprising, this finding, but it's underlining the fact that there is something in delta age which is telling us much more about cardiovascular risk than the risk factors measured cross-sectionally. And this could be because delta age is really telling us some of the cumulative insults that the heart may have received over someone's lifetime from a wide range of different factors. So in conclusion, delta age is an individual level biomarker that differs substantially between a high CVD mortality country, Russia, and a low CVD mortality country, Norway. These differences are only slightly attenuated by adjustment, and the widespread availability of ECGs and the relative ease with which an AI algorithm can be applied to derive delta H makes it a very attractive prospect to do future research on, to understand determinants of differences in CVD risk, both between individuals and, crucially, between populations. And the substantial difference in delta H between populations is consistent with there being accelerated rate of cardiac aging in Russia compared to Norway, consistent with the large differences in CVD mortality. So acknowledgements to various people, all members of the Know Your Heart and Tromsø study teams, Sergei Trias-Limas for his initial analyses that I showed you, and the study participants in the 3 settings, and of course to our funders. Thank you very much.